Thank you for your invitation. I'm just going to go for your kind introduction. I'm a clinician, so the way I give this talk is to make it more like a journey that I went through, which would be more. I felt like this sort of talks would be more interesting for students, more younger generation who want to go through this research path and share with them the obstacles and hopes and excitement, etc. So the way how I got involved into this targeted delivery is shown here by this slide. So I do see transplant patients, and my clinical work is going down more and more because I have to write more grants. But this slide applies pretty much to a very large number of patients. I would say millions of patients, which basically receive some kind of immunosuppressive drugs for transplant condition, because you need to accept the organ forever. You get the organ from another person, and if you don't get immunosuppression, you reject the organ. Therefore, you would need medications for entire life. So what we do, we give a combination of several immunosuppressive medications for the rest of their life, for 2, 3, 4 medications. And what happens is that over time, these are very strong immunosuppressive drugs. They're very potent. They suppress nicely transplant rejection, but most patients die of complication, actually. So in the case of, for instance, kidney transplant patients, most patients die of cardiovascular disease. And that's because largely because this medication causes toxicity. And it's not just for transplant. This could apply for rheumatoid arthritis. They also need immune suppression. It could be all kind of autoimmune conditions, type 1 diabetes, all kind of diseases that now more and more require immunosuppressive drugs. You have the same problem. So, typically in a clinical setting, what we do is that we cut down the immunosuppression, try to reduce the toxicity. But what happens most of the time is that the rejection takes place. So most of these trials that we've done to replace one drug versus the other one hasn't been that successful. So I got across with the term nanoparticle many years ago, and I was talking to my engineering colleagues. They were talking about drug delivery, and I said, that's a pretty interesting concept. Can we deliver immunosuppressive drugs to specific sites? And at that time, most of the trials, most of the efforts were gone into the tumor, because 95% of the efforts in nano-targeted delivery was to get the drugs to site of tumors. And you get a number of benefits from packaging a drug into a nanoparticle, but I think most people are interested in this one, where you can get the specific drug to a specific site in body. So this paper published by leaders in the group, and they basically say that, despite a massive expansion of studies in nano drug delivery, there has been a gap, which basically talks about low translation, meaning that there's so many papers being published and excitement gone through the roof. But when it comes about translation, there has been a gap here. So this slide pretty much shows some of the issues with nano delivery. Basically, this is how it started. It is a concept called passive targeted delivery, where the vasculature of tumor is thought to be leaky. So you make the particle drugs inside the nanoparticle and inject intravenously, and the particle home passively to environment of tumor, because the vasculature of tumor is disorganized and leaky. But we learned more and more that actually this is not the case. A lot of tumors, the tumors that are so-called, especially cold tumors that don't respond to therapies, they're actually quite fibrotic, meaning that the leakiness is not the case. So more and more people go after so-called target delivery, where basically you conjugate the surface of nanoparticle with antibodies or some kind of peptides that recognize certain receptors on your targeted cells. It could be, a cell in the kidney, in the liver, But the rule of thumb is that the receptors or that you're interested to target should not be widely expressed, because then you're going to target a large number of cells, different tissues. So, but most of the time, I would say, people use antibodies on the surface of this particle, put a drug inside, but you can, put different sort of targeting that can be applied. So this slide shows some of the problems we have in nanoparticles. So you have old school nanoparticles, which is lipid-based and polymer-based. But then it gets complicated, meaning that it becomes more and more new materials. So when you go toward more newer materials, it becomes, fancy, innovative, but their translation is going to be much slower, right? So I realize for the fellows, if they want to get better CV, better publication, better impact factor, so they naturally want to go after highly innovative materials. And but the thing is that if the plan is to go to patients and increase the translation, you have to think about materials that are more tested. So these two types of materials have been used more widely, and their safety profile is much better studied. So that's a trick that is very hard. I mean, how you can say to a younger fellow to pick up an older nanoparticle and good translation, for a established professor maybe it's a good thing, but for the newer crowd, they want to have better CV. So this is a interesting obstacle that I noticed. So as I show you, one of the critical things to remember is that the environment is not as leaky as we think. See, this is the vasculature that, let's say, you're hoping that nanoparticle are going to pass through. So in the case of, for instance, tumor, or in the case of transplant organ, there's a significant amount of ECM is built around the vein, around the vasculature. Here is fibronectin is basically shows fibrosis. And if you cut your skin and you have a big scar, you're going to see massive accumulation of fibronectin. So this is a tumor microenvironment. You see how much fibrotic material has been made. So the passive delivery is not as easy as we thought. It's not like a prevailing theory anymore, because even in the case of tumors, there's quite a bit of materials made. And there's been studies actually in the past that if you inject an antibody, less than 1% actually gets to the tumor. So let's say this is a tumor environment and you inject an antibody with a drug. Antibody needs to go pass through here and pass through here to get this tumor. When it comes about drug conjugation, it's a very easy concept. You say, I made an antibody that recognizes this tumor and sticks to these tumor cells, for instance, here, and then brings the drug inside. But most people don't talk how this antibody gets from here to here, you see. So this is a very, very important angle to think about it. That's one of the problems with the drug delivery, is that most people don't pay attention on this path, that this big molecule, the antibody, needs to pass through this vasculature. So we became interested in two sites in transplant. So in transplant, so this is an organ that is being transplanted in a patient. So it comes with those own antigen presenting cells. These are the cells that present antigen. They reside in the tissue, donor tissue. And when this antigen, basically of donor antigen, is being recognized in the lymphoid tissue of host. So remember, immune education takes place in lymphoid tissue, doesn't take place in blood, right? So that's a very critical point to get across for engineering people, that most important site of immune activation is in the lymphoid tissue. So these are two sites that most people don't study actually, because most people are like to study tumor itself. That's another obstacle. I realize that, because 90-something% of people are interested in getting the drug to the tumor, right? And the reason for that is because most people who started in nanodelivery came out of the cancer school, and they've been taught that if you get the drug to cancer, you get better outcome, which makes sense. But we know more and more that the lymphoid tissue is a primary site of tumor immunity, right? So if you're able to get there, you can change the immune response against the tumors or transplant. Here is basically an interesting slide that I like people to pay more attention, especially for the younger crowds, that these are a number of lymph nodes that everyone has. It's about 300 lymph nodes in human. And they're everywhere. So every organ drains to a specific lymph node, breast, GI, they all drain to a specific lymph node. So these lymph nodes constantly monitor the milieu of tissues. If you have a tumor coming up, this person can have, for instance, breast tumor. The very first place that drains is in this lymph nodes in axillary area. So this is going to be called tumor draining lymph node. You put a kidney organ transplant, lymph nodes around this area can get the antigen. So it's very important to understand the lymphatic drainage and lymph node. So if you get to this size that they're pretty much educate T cells, educate immune cells against tumor or against transplant, you can change the immune response. So in the case of transplant, you want to reduce it because you want to accept the organ. In the case of tumor, you want to actually increase it because you want to increase tumor immunity. So what people do typically is that they get a needle and directly inject to the lymph node. You see here is one very simple, crude way. You get antigens, tumor antigens directly injected, and you get tumor immunity. You put cream, and these are old school. Basically, you use lymphatics. You don't use lymph. You don't use vein. This is actually known for 200 years. So like in late 1800, there was a famous German pathologist would section lymph node from people who died with tattoo. He would see that ink is actually in the lymph node because the ink actually goes through lymphatics, through the skin. So this is a very old school, or more than 200-year-old known fact that for visceral tumor, this way is not going to work because you need to access the lymph node and you need to go through systemic IV injection. So one of the interesting things about lymph nodes is that they have a very special vein, which is called high endothelial venule here, shown here, where which express this molecule, which is very interesting and exclusive. It's called PNAD, peripheral node addressing molecule. And this is a sugar-coated molecule that expressed on this class of vein. And me and Pilhan's group has been working quite a bit on this vein for a number of years now. And so this vein, you're born with it in your lymph nodes. So you in your 200-300 lymph nodes, you have this vein. And the reason they're called high endothelial venule, or I'm going to call from now on HEV, is because they have so much Golgi and the plasmic reticulum to make this very complicated sugar-coated glycoprotein. So how they look like here. So this is an old way of staining a lymph node. You see this is a high endothelial venule. This is a standard vein. Why is that? Because high endothelial venule are bigger, and you see the dots inside of it, the bubbly looking, it's called cobblestone formation here. And the reason is because they're very chubby. There's an immune staining of high endothelial venule. And that's their job is actually promote T cell homing. This is a lymphocyte that passing between two endothelial cells of high endothelial venule. So this image that I'm showing here is very important. Just imagine in your 200-300 lymph nodes, every 10 seconds or every minute, millions of immune cells pass through this. Meaning for past, like let's say 10 minutes I started, billions of immune cells went through all your lymph nodes and look for materials. If you had a, God forbidden, tumor or whatever, they start going to react in the lymph node. So their job is to bring T cells to the lymph node. So it's very highly regulated. The reason this vein is only in the lymph node, because only lymph node does T cell homing. You understand? So that's very important. So T cell homing happens. So this is, for instance, immune cells that the electron microscopy of high endothelial venule again. This is an lymph node. You see, this T cells is squeezing inside. These T cells beginning to stick into high endothelial venule. This shows multi-steps that these immune cells constantly interacting and passing through. So this lumen basically is a gate for immune cells to home to lymph node. And if you active that lymph node, meaning that you put a skin transplant, you put the toxin, the lymph, or you probably all had the sore throat and your lymph node got bigger, right? So that your high endothelial venule is going to look like this. Becomes flat because it has to bring so many immune cells to the lymph node that drains your neck because now you have infection. So all these T cells that you see here, they're passing through, is that you need to have immune activity in the lymph node because you have a sore throat. So that's basically it. T cells underneath the high endothelial venule. And if you stay for T cells, they're all around this high endothelial venule. These are all T cells in the lymph node because they do homing of this lymph node. And they're actually near lymphatics. So this is the sugar-coated, we call it PNAT, which is exclusively expressed by this exclusive vein. T cells home to pass through this by bonding to this sugar-coated molecule through their selection. So the antibody that we use is an antibody that recognizes this epitope, and that antibody recognizes this vein, which is called MECA79. So that's the vein that does T cell homing. This is the work we did with Pilhan with his microscope, which was quite. We almost had it like for a few months, and we got so much out of it, and it was such a quick and short interaction, but it was so fruitful for us to get so much data out of it. And you can see these T cells this is HEV structure, and these are T cells that are crawling, that they're trying to pass through this lymph node. When you can see how this is old school, we tried to do. I think we did this with Andy's boss, Pilhan, and we did, or with Andy maybe. But at that time we didn't know how these nanoparticles we started injecting, and the problem is that you see this thing is moving. So we were trying to optimize it. This is a nanoparticle that we made it, and we're trying to optimize it. But here, this concept is shown here. Basically, our idea is that. Basically, we want to make a nanoparticle here and put a drug inside the nanoparticle. And on the surface, we're going to put this antibody, which is called MECA79, which I told you that recognizes this PNAT. So the nanoparticle binds to this PNAT, gets internalized, and releases a drug in this neighborhood. So that's the concept. And the drug of choice, again, in the case of transplant or autoimmunity, could be immunosuppressive drugs. Here we show a drug called TAC, which means tacrolimus, is an immunosuppressive drug we use for transplant. And this is a drug they use for all kind of autoimmune conditions. So our goal was to deliver a small amount of this drug in this lymph node neighborhood, this area, and to get better T cell suppression. So when we started, we didn't know what to do. And, we worked with the chemist, and we try to play around with immunosuppressive drugs. Here's another immunosuppressive drug called cyclosporine. And the reason was we were excited in this sort of things because that time, nobody was interested in immunosuppressive drugs. Everyone was interested in putting cancer drug. So we tried to say, well, we cannot now put immunosuppressive drugs in this nanoparticle. And then we say, well, can we deliver these immunosuppressive drugs to a mouse, to a lymph node? So we conjugated the surface of it with antibody, MECA79, with the drug inside of it, and on the surface was antibody. And because we didn't know what to do, we actually came up with microparticle that time, because we thought that if we make a bigger particle, we can put more drugs to it. Then we later learned that we should reduce the size. So when we put a tacrolimus in this microparticle, we found that actually we get few days prolongation of heart transplant in mice. So in mice, what my microsurgeon does is get the heart from one strain of mouse, put in the abdomen of the recipient, so you don't take out the host heart. So the donor heart is anastomosed to the recipient aorta, and it beats. And when it rejects, it stops beating. It's a very powerful immune response, and the heart actually. 99% of these hearts reject around day 9. So if you go by day 15, you cannot even find the heart, because it's such a potent immune response against transplant that the organs are all going to be basically melted. So what we found was that we get drug delivery, but the prolongation that we saw, which is this group that we were interested, wasn't that amazing. Just only few days of prolongation. However, the amount of tacrolimus level in this group was much lower. So we felt that there's a delivery. We found that there's some prolongation with lower tacrolimus level. This is the thing that kills the patients, very high tacrolimus level, where you get toxicity in heart, diabetes, all sort of things. So it wasn't amazing, but it was promising. One of the questions came up all the time was that, so if you have 200-300 lymph node, why should go to active lymph node, right? Because when you put an organ transplant, you activate certain lymph nodes. In the case of tumor immunity, certain lymph nodes that drain it, they're going to be active. So what we found was that the active lymph node or drained lymph node, you have a massive expansion of high endothelial. This is IDISCO staining that we did. And we basically got rid of every relevant materials out of lymph node. And this is the entire HEV of a naive, very small round. So the idea is that when the lymph node gets active, the HEV gets expanded. Therefore, you get higher amount of drug to active lymph node. And here another example. Here is the naive lymph node. You see the HEV is very round, but when you active lymph node, there's a massive expansion of this vein early on. And the other reason that they may go higher to the active lymph node is the blood flow. You see this naive lymph node, the blood flow is very small. This is an active lymph node with massive amount of blood going through lymph nodes. The classical example is the sore throat. This is a transplant lymph. This is a lymph node that drains the transplant. But this is the same concept. When the lymph node gets active, gets bigger because they need more space for T cells, and the blood flow that goes to the lymph node is significantly higher. So this is the reason that we think that active lymph node gets more blood, therefore more HEV, therefore more trafficking. So because when we did microparticle, we realized that a lot of them get stuck in the lung, we started making our own nanoparticle. We brought the size down to 100. Again, the reason most people do 100 because came from cancer world. Again, because we do these things, as another lesson learned, is that we do these things because other people have done it. We pick up that style, but we should think again for your own model. Right? Because this concept of 100 or 75 came from tumor world because they want to have a significant circulating time to go to the tumor. They want to actually avoid the spleen, and they want to avoid lymph tissue because they're more concerned about immune reaction. But if you, now, because we know more and more about tumor immunity, maybe actually you should change the size a bit more and try to get to the spleen more and try to increase the tumor immunity. So what I'm trying to say is that we should always think about what people learn from their models, and that when you apply to your model, think about your own physiology and anatomy. Here is the basically mouse. We put the skin transplant on the back of the mouse. And typically this lymph node in a mouse gets really big. You don't need to have a microscope. The size gets huge post-transplant. And we showed that we put an infrared dye in this nanoparticle, and this particle had the antibody on the surface. And you can see these lymph nodes become hot. This is draining lymph node. And if you examine the sections of this lymph node over time, this is the HEV structure of a lymph node. Few hours are mostly the HEV complex. And as time goes by, this particle migrates out in the lymph node into the HEV. So when we did more staining, we find that this dye sticks around for 3-5 days. So it's very hard for us to understand the kinetics of the drug, meaning that you have to do HPLC or very fancy stuff. We haven't done those things, but it seems that the average half-life of this particle is about 4 or 5 days because these are biodegradable particles that breaks down. So this round, we said, well, we want to put a drug that is more clinically applicable. You see, in that drug that I told you about, tacrolimus, is an immunosuppressive drug that you take for the rest of your life, right? A transplant patient takes it every day, twice a day. So that's a cool science, right? Because you say that, but you know that clinically is not going to happen, right? I cannot give nanoparticle to a patient every day unless this causes magic thing, right? So when you, again, if you want to increase translation, you need to think about how this product going to be used by physicians, because if you say that you need to take this nanoparticle for a long period of time, they're going to say, well, my patients even don't take their own simple pills. How am I going to take them to come to clinic and get this nanoparticle? So we said, well, we want to do a practice or do a drug that used for 4 days, 5 days. So this class of drug called depleting agents, this is called anti-CD3, which is an antibody that depletes immune cells, basically wipes out all the CD3 cells. And they're called depleting agents. And they're actually very commonly used in a wide variety of immune conditions that are lethal, like let's say lupus patients or diseases that, or bone marrow transplant, diseases that you really want to give a lot of immunosuppressive drugs for a short period of time. And we call it induction, meaning that you induce significant number of immunosuppression and then put them on maintenance, like tacrolimus. So if you come, say, to a physician, instead of giving, like, I don't know, 2 milligrams per kg of this drug, and a large number of patients get infection, malignancy because they're very toxic, or, I can cut them by 100%, but you have to give this nanoparticle 3 times only. It's clinically feasible. So the reason we went for this drug was that we want to make sure something that is clinically more feasible. So the concept was the same. We put our antibody inside the nanoparticle, and outside of it, we put our antibody, which is a MECA79 here. So in the case of free drug is this one. Remember, as I said, this mice rejected on day 10. So if you give the free drug, it prolongs it very nicely. You see, it brings it from 10 to almost 30 days. And if you give this drug with this particle, it significantly prolongs. So, and the injection was about only few injections here. Wasn't giving for all time. And this drug, remember, it causes tolerance, meaning that it doesn't need to be given every day. And, more recently, we actually went through other classes drugs, which are called co-stimulatory blockades. And this is work that we did with Pilhan. And the same concept, these are newer class of immunosuppressive drugs, but that if you're able to get them to the lymph node, you get better tolerance with lower drug needed. So, as I said, lymph nodes, you're born with those lymph nodes, with those high entherovenal. One of the concepts that we've been working with Pilhan is widely known now that the tumor, for some reason, and inflamed organs make their own high entherovenal. Remember, those are physiological vein in your lymph node. And these are called tumor-associated HEV or ectopic HEV or high entherovenal. So these are pancreatic tumor. They're all expressing this unusual vein that pancreas doesn't have it, right? Pancreas doesn't do T cell homing. And they're formed in the middle of cancer. So that made us think about, can we do drug delivery? Because we already figured out how to hit this vein. Can we figure out drug delivery to tumor? These are various forms of human tumor that you can see this vein. This is a pancreatic tumor, which particularly shows quite a bit of expression of this vein. For some reason, we're trying to figure out, we have a paper for Pilhan specifically on mechanism of induction of this vein. And you can see across all tumors, they have it. And the reason people more and more becoming aware of it, because they put antibody to it, right? Because the people are getting interested in this vein. Remember, this vein does T cell homing. So, and checkpoint inhibitors and, tumor immunity is very hot now, right? So if you know how to make this vein, the idea is that you can get more T cells, right? And then that be a major cornerstone for tumor immunity, right? Because cold tumors don't do T cell homing and they're cold. So one of the things that we found, which I think is quite amazing and it's not being still appreciated, is that metastatic site also makes it, right? So this is known. This is quite widely published in the case of primary tumor. But this is the metastatic site of a patient who died with breast cancer. The lung actually has more of this high endothelial than the primary tumor. I don't know why. Maybe because when they go to the distant metastatic sites, maybe they have more progenitors there. And maybe those sites have, cells have be more prone to metastasize and maybe have more enriched with HEV. We haven't quantified it, but it looks like that way. Here is a patient who died of duodenal cancer, pancreatic cancer, who metastasized to duodenum. Again, this vein is made. We actually grinded the pancreatic tumor and injected it into portal vein of a mouse. And you see the edge of the liver is the pancreatic tumor. You see that? It's the white-looking pancreatic tumor is being made, because this is like takes several weeks. This is a tumor, and in the middle of tumor, this HEV is being made. So we see basically the concept that we are pushing, or we are setting forth, is that you have primary tumor that you have HEV, you're born with lymph node that you have HEV in it, and you have metastatic sites that seem to have HEV. So if you target HEV, you may get triple site delivery, right? So this triple site delivery has never been achieved with one injection, basically. So that's the thing that I'm very excited about it, that maybe we're able to get this triple site delivery, because this site is, as you know, most people are working, right? 99% of people are working on this site, because you're looking for a tumor antigen, you get an antibody, and you do drug delivery to it. These two sites are bottleneck issues, right? Because getting drug to these two sites is almost impossible. So if you have one route to get to three sites, I think is a really exciting. This is a beautiful image that Pilhan made. This is a lymph node, and basically this area, these are the GFP melanoma that are basically colonizing the lymph node. So this could be a lymph node of a patient with melanoma. So just shows that how important it is to get to the drugs to these sites. Okay, and we basically put the tumor in an NSG mouse, the pancreatic tumor that had the HEV, and we made our own particle. And you can see that mouse that had the pancreatic tumor that received MECA79 infrared dye is hot now. So we showed that this tumor, actually, you can get the nanoparticle to it. And that time we put a Taxol to it, and group that received chemotherapy with the MECA79 MP, they had much smaller size tumor. So we showed that the particles home to the tumor, and you can get smaller size. So this is the concept that we are promoting, is that you have particle that sticks to this primary HEV, which has the PNAD, right? Because you have it, you're born with it. And with this, you can actually hit the tumor drain lymph node. Then you have primary tumor that express the same molecule, and you have distant HEV that has the same molecules. This basically explains the so-called triple site delivery that express the same molecule. And although the structure of HEV might be different, that's why people were interested in these two things. But you should remember that the HEV doesn't look like classical HEV. So if they stain it and start seeing the structure is not as beautiful and bubbly looking, chubby, fat ones, remember that this size, the HEVs are not well organized. So, but they do express the same molecule. So we had a collaboration through Pilhan's colleague, who actually introduced me to Pilhan, through Kenji, another outstanding colleague of mine. It was truly a pleasure. So through Kenji, I got to know Pilhan. So good people introduced to good people. That's another rule of collaboration, which is very important lesson, right? So I got to know Kenji and Moto, and with Moto and Kenji, we actually tried to make our own antibody, because the antibody that was commercially available was MECA79. We said, well, that was actually made in 80s by grinding the lymph node and injecting. So we said, well, we can use the CHO cells that express the PNAD and inject in a mouse that they made it actually knockout. So it's a very complicated knockout mouse, because in order to knock out the PNAD, you need to do multi-knockouts, because the sugar-coated glycoprotein needs to be knocked down in different enzymes. So Kenji had that mouse, and we immunized it, and we made an antibody. We call it now MHA112, and this is the antibody that we made. And the concept is the same. We think that it binds a different epitope than MECA, but here we changed our strategy a bit. We are not making nanoparticle. We're directly putting the drug to the antibody, which I think makes the translation easier. there is a benefit and pros and cons for using nanoparticle versus direct conjugation. In this case, I think I find it more interesting to get to the patients, because getting nanoparticle, putting drugs, all FDA regulation, etc. If you can get the drug directly to the antibody, I think it makes it easier. So basically, we made the antibody and put the dye to it and injected this antibody home to the lymph node. The same thing happens, dye is leaking out. And we put the drug now directly conjugated to our MHA here in the case, non-nanoparticle. And this is a breast tumor, which actually expresses PNAD, because this is a newly made high endothelial in the tumor. And, the mice that received the Taxol MHA-112 versus free drug had much smaller size tumor. And what is interesting is this, which, again, this is concept that we are working with Pilhan, is that this is a free Taxol group. You see the lymph node of a mouse with the tumor? It's very small penetration, even a small molecule, which is fascinating because first of all, most people don't know what is the kinetics of drugs to lymph nodes, which is also a very interesting concept. People are interested in pharmacology because I always look into PubMed, how many people look into kinetics of checkpoint inhibitor in lymph node. Nobody knows. Nobody pretty much wants to know because when you are focusing on one thing, you always do one thing, right? So one thing that I really recommend, or people who are really good into pharmacology, is to really understand what is the kinetics of these drugs that we give to mice with cancer in lymphoid tissue. We just don't know that much. Right. And this is actually a very crude way. It's not really advanced. It's just a dye being given to Taxol is a relative measurement of the penetration of drug. It's not that great, even in small molecules. Now we are going with our antibody. The penetration is much better to this lymph node. That means that we get better kinetics of chemo drugs to the lymph node. But one thing we found, which is quite fascinating, is that the lymph node appears to be like a tumor. You know how I show you the tumor is fibrotic? Is that in the lymph node that coming from a tumor, they also make scar. So that means that the lymph node becomes similar to tumor fibrotic. And I think that's the reason that these tumors become cold and the lymph node becomes fibrotic, that the immunity goes down. And our hypothesis is that by getting drugs more effective in lymph node, you can change the stroma back to the normal. I think here is the group that MHA Taxol got. So you see the collagen here is very thick. Laminin is very thick. This is almost like a scar. If you get more drug through MHA Taxol, which are antibody, they become thinner. You see this? It's not perfectly normal. I don't have it normal here, but they look like become normalized. So that means that this drug delivery, with more effective drug delivery to this lymph node, you get better stroma, and that should give you better immunity. We see the same thing in the distant mets, the same idea. If you section distant mets, the same high collagen, and show the year that in our metastatic models, we get smaller size tumor. And this is, again, one thing that is very fascinating that I was talking to Pilhan about imaging, right? So is about diagnostic. Remember? So it's not all about therapy. Actually, one of the biggest problems in tumor word is that you need to stage lymph node, because physicians, the way they treat patients is that the lymph node is involved. So breast tumor patients, whether lymph node is involved, they take that lymph node and start sectioning, and it's very archaic, right? It's not really advanced. So what we here is showing that this lymph node that gets bigger and more HEV becomes basically hotter. So the same delivery, but you need to put an image in contrast that is feasible for clinical practice, that you can say, well, I have a patient coming and I injected with this antibody and put a PET scan dye or something that I can see a hotspot in lung, right? Because lung should not have hotspot, right? Because lung doesn't have HEV. And now you have a pancreatic tumor who's got lung hot spots in lung or liver, you know that this patient has distant mets. Another important aspect is that autoimmunity. The concept of lymph node is extremely important, that the lymph node is not just tumor immunity, it's actually inappropriate immunity against your own antigen, which is called autoimmunity, is also in the lymph node. In the case of pancreatic lymph node, PLN, autoreactive T cells are made actually in the lymph node that drains pancreas. So if you get to here, you can get better anti-diabetic effects. So for the case of organs, for the kidney, we made a model where we targeted the receptor on the proximal tubular cells called megaline. And in this case, actually, we put a light chain because in your body, light chains are produced more and they excreted by kidney, but they're pecked by proximal tubule expressing this molecule called megaline and goes inside the proximal tubule and breaks down. So in this case, we actually didn't use antibody, we used light chain. And this is a route to get to the kidney. Could be an interesting route for this is the proximal tubule for kidney cancer. Could be an interesting route for treating immune conditions of kidney, like lupus nephritis, for instance. This is actually an interesting figure. Transplant is the only condition that you have an organ in front of you, right? Because in no other places you do that, right? You don't go in a patient, take the liver for liver fibrosis, right? Treat the liver and put it back, right? So transplant is the only condition you have. So this is a fascinating situation where you can actually do a lot of things to the organs prior to putting to the patient. So one of the big obstacles that we have is that when you remove an organ from a donor, that time donor organ is inflamed. So one thing we could do, we can actually treat this with nanoparticles inside these organs and suppress the inflammatory responses in these organs by putting nanoparticles to these organs. And this can happen prior to transplant. So this route is the most effective way to protect the organ in the host. But what we do now is that we put the organ in a patient, right? And we give this patient a lot of immunosuppressive drugs that are toxic. First, again, this is another problem. We don't know how much drugs get to this organ where basically is the site of inflammation now because all the T cells and macrophages want to go there, right? So if you have the organ already with nanoparticle, that drug is being released, you get a protective effect from day zero against inflammation. So this is a very interesting, important concept. So we started this approach where basically nanoparticles that, in this case, we have a drug called CellCept, is a vascularly safe drug. So you don't want to give actually tacrolimus, for instance. I don't think that, because tacrolimus is very vascularly toxic. So if you inject a lot of it to the organ, you get toxicity. This drug is more like pure immunosuppressive drugs. And we inject it directly into the mouse heart and then transplanted the heart back into this. So we were planning to get these drugs to the tissue of the donor heart prior to transplant and show that some of them picked by macrophages of the tissue. This is 11B staining of the heart. So we show that these particles are being picked up by macrophages that are in the heart. So you get the immunosuppressive drugs around these macrophages getting released, and then you transplant this heart back to the host, and we should get protection. One of the drugs that we are very much interested in is the anti-IL-6, because we are thinking that IL-6 is a significantly pleiotropic cytokine that causes massive augment the immunity against the transplant rejection. And they do it in different ways. It's not just one way. So if you target this pathway in the organ prior to transplant, our hypothesis is that you get much better protection. Here, for instance, we give local, meaning that we just give the anti-IL-6 to the organ and compare it with when we give it with systemic anti-IL-6, meaning that either give significant above drug to a host IV or give much smaller amount to the heart transplant prior to transplant. So you either give it to small amount to the organ, protect the organ, or give huge amount to the host. And we found that actually through this route, meaning through nanoparticle route, we get much better protection with much less anti-IL-6, which better efficacy and less toxicity. So here we're collaboration. We have the MGH, and we're trying to do some of these large animals. This is the lung transplant. this is a very interesting tissue because it has quite a bit of macrophage in it. So we are pre-treating these long transplants with nanoparticles and trying to study the trafficking and kinetics of the uptake of these particles by macrophage. This idea is actually being pursued by quite a bit of colleagues now. And here is a group where they're making nanoparticles where the drug is delivering this drug called rapamycin. This is, again, another immunosuppressive drugs which causes immune regulation. And again, but the concept is the same, pre-treating the organ transplant prior implanting with an immunosuppressive or immune modulatory drugs in order to get better protection. Here they use a drug called rapamycin. So the pre-transplant, pre-organ transplant nanoparticle delivery, the target doesn't have to be transplant rejection. One of the problems that we have with transplantation in general is that we actually discard quite a bit of tissues. A large number of organs being discarded because their quality is not good. They are ischemic, or they've been in ice cold for too long. They have thrombosis, et cetera, et cetera. So, our liver, for instance, there are no massive number of livers are discarded because they're non-metabolically good. So, one of the cutting edge idea is that you treat these organs. You basically make a center which you can modify these tissues and then transplant them. You follow what I'm saying? So this is a very interesting concept to increase the utility of marginal organs. And again, it doesn't have to be what I'm trying to say. It doesn't have to be antibody. It doesn't have to be a drug that I'm talking about. So you could come up with your own drug. For instance, one can say, well, can I deliver siRNA, for instance, or can I deliver CRISPR type things, or can I deliver a drug that reduce fatty liver? Because some of these livers that we discard, they are fatty liver, right? So you say, how about pre-treating these organs, make them metabolically more fit, right? So it doesn't have to be anti-IL-6. So this concept is something that people should think more and more about it. And the interesting thing about this platform is that a lot of transplant surgeons, physicians, scientists don't have nanoparticle expertise and would be interested in collaborating. And that's one thing. So this group is actually trying to look into and the other thing is that a large number of these organs go on a machine, meaning that the blood goes through these organs constantly. So if, I don't know the situation in Korea, but if the organ comes from California, 6, 7, 8 hours to stay on a pump, and you can put these materials in the pump and constantly perfuse this thing. So that's a very low-hanging fruit that I think would be very important. Here they're trying to target endothelial cells, and by targeting CD31 and try to increase the utility of these ischemic organs. And this is another group from our center. And Jamil was my fellow, actually. He started that cyclosporine idea, and he's taking this very cool idea where you're using this gels that release IL-2. And this is interesting cytokines that being used for tumor and transplant immunity. Basically, a way to release IL-2 and get transplant outcomes. And they're targeting Tregs. Trained immunity is a hot topic nowadays, and this is a colleague of mine. They're trying to use another form of nanoparticles, the lipid-based nanoparticles, APOL1, and they're trying to deliver drugs that reprogram macrophage and retrain immunity by drugs that they're interested in. So this is another approach, and they're injecting systemically, but their target is different. Is not targeted, meaning that it's not targeting specific organs, it's just systemic, but they're targeting macrophages. So when we talk about targeted, always be clear that what it means targeted. In a nano delivery platform, targeted means that you're targeting a site. So targeted could have different meanings too. If targeted could be a pathway, this is targeted, or it could be the site that you're delivering, which could be targeted. and they put this in monkey and show outcome. And this is another way of delivering using. But again, they're using different kind of drugs. Here is the JAK inhibitor, statin inhibitor, and to enhance these effect of co-stimulatory blockades. That's it. So I'm going to stop here and answer your questions. I think I want to also thank again Pilan with his team, and it's been a great collaboration. And I think I told Pilan that maybe one day I show up in Korea, but increase our collaboration. And this is a place that if his students or people who are interested in interacting, can always join us, and we welcome, people from Korea and increasing our collaboration. Thank you.